In this video, I'm going to talk about the shoulder kinesiology, biomechanics, and anatomy. There are totally 4 joints that contribute to the shoulder structure. They are known as the acromioclavicular joint, the sternoclavicular joint, glenohumeral joint, and scapulothoracic joint. First, let's talk about the angulations. In the horizontal plane or transverse plane, we see that the scapula is 30 to 40 degrees facing forward or anteverted. So it forms the scapular plane. Also, humerus is 30 degrees facing backward or retroverted, and clavicle is 20 degrees retroverted. If you look at the humerus in the frontal plane, we see that there is an angle between the shaft and the head of the humerus. This angle is known as the angle of inclination. It's approximately 130 to 135 degrees. And also we saw that in the transverse plane, the humerus is 30 degrees retroverted. Now let's focus on each joint. The first one, the sternoclavicular joint, is a saddle joint. The important ligaments are anterior and posterior sternoclavicular ligament, interclavicular ligament, the costoclavicular ligament. It has 2 bundles. It has an anterior and posterior bundle. And also between the sternum and clavicle, we have a disc. The close back position of the sternoclavicular joint is maximum elevation with protraction. But what does the saddle joint mean? When a joint in one diameter is concave and in the other diameter is convex, that means the joint is saddle. So when we look at the clavicle, in the longitudinal diameter, it's convex, and in the horizontal is concave. So in movements such as elevation and depression, this is convex on concave. As a rule of thumb, when the movement is convex on concave, the rolling occurs in the same direction as the movement, and sliding occurs in the opposite direction. So when we are doing elevation, we have superior rolling and inferior sliding, and the opposite, the depression, is rolling inferiorly and superior sliding. But the other movements like protraction and retraction are in horizontal diameter, so it's concave on convex. When it's concave on convex, the rolling and sliding happen in the same direction. So in case of protraction, we have rolling and sliding anteriorly, but retraction, rolling and sliding posteriorly. So it was the arthrokinematics of the sternoclavicular joint. Now let's talk about the second joint, the acromioclavicular joint, AC. It's a plain joint. The important ligaments are superior and inferior acromioclavicular ligaments. The coracoclavicular ligament is coming from the coracoid process of the scapula, and it has 2 bundles. We have conoid and trapezoid bundle. And in some people, we can find a disc between the acromion and clavicle. The type of the movement is adjustment movements. What does it mean? When we are doing movements such as abduction or flexion, the acromioclavicular joint and the sternoclavicular joint have to adapt themselves. So imagine we're doing abduction. The acromioclavicular joint has to do upward rotation, and for adduction it has to do downward rotation. For protraction or retraction, the AC joint does internal or external rotation. So they're known as adjustment movements. Next joint is the scapulohumeral joint. It's a false joint because the scapula and the ribcage are not in direct contact because they're separated by layers of muscles. And for the scapulohumeral joints, as I told you earlier, we need acromioclavicular and sternoclavicular adjustment movements. And last but not least, the glenohumeral joint. It's a ball and socket joint, meaning it's convex on concave. The head of humerus is convex and the glenoid fossa is concave. So we saw earlier that the humerus is 30 degrees retroverted, and the humerus head articulates with the glenoid fossa. And in an analogy, we can compare that to a golf ball and a golf tee. So just 1/3 of the head of the humerus is in direct contact with the glenoid fossa. So that's why dislocations are a common phenomenon in the shoulder joint. But where does the stability comes from in the shoulder? We have two types of stability. We have static stability and dynamic stability. So static stability comes from structures such as ligaments, tendons, and the shoulder capsule, the tendon like the ligament of biceps tendon. And the dynamic stabilizers are the muscles. Totally 16 muscles attached to the scapula, and the most important ones are the rotator cuffs. They hold the head of the humerus tightly in the glenoid fossa, and they prevent the dislocation in the shoulder joint. Okay, let's talk about the glenohumeral joint arthrokinematics. We said that when it's convex on concave, the rolling happens in the same direction and sliding in the opposite direction. So when we're doing abduction, it's rolling superiorly and inferior sliding. When it's adduction, it's inferior rolling and superior sliding. When it's flexion, it's different. It's posterior spinning, and in case of extension, it's anterior spinning. In case of internal rotation, it's rolling anteriorly and sliding posteriorly. And for the external rotation, posterior rolling and anterior sliding. It's the arthrokinematics of the glenohumeral joint. We have a very important structure in the shoulder joint. It's called the labrum. Labrum is a fibrocartilaginous structure. It deepens the fossa and provides stability in the shoulder joint. It increases the contact surface by 75% in the shoulder joint, and it assists holding the humerus head in place. There is also another anatomical structure which is very important. It's known as the subacromial space. This space exists between the acromion and the head of humerus. It's approximately 1 centimeter. There are some structures in it, such as the supraspinatus tendon, the long head of biceps tendon, and subacromial bursa. In some conditions, when there is impingement or extra strain on the structures, is known as the subacromial impingement syndrome. We have two types of subacromial impingement syndrome. We have primary and secondary. The primary is when there is an anatomical abnormality. For example, when the acromion is hooked, it exerts extra strain on the tendon. And the secondary is due to muscular abnormality, when there is imbalance between the shoulder muscles. When we want to do movements like flexion or abduction, the scapula, the glenohumeral joint, AC joint, and the sternoclavicular joint, they have to work in a coordinated manner. It's known as the scapulohumeral rhythm. We can divide the movements. Just imagine the abduction. We can the full range of motion is 180 degrees. We can divide it into 3 phases. The phase 1, from 0 to 30 degree, is known as the scapular setting phase. In this phase, the scapula doesn't move that much. We only see the movement in the glenohumeral joint primarily. But in the second phase, from 30 degree to 90 degree, the movements are in a 2-to-1 ratio. So for every 2 degrees of glenohumeral rotation, we have 1 scapular rotation. And phase 3 is from 120 to 180 degrees. And as I said earlier, we need adjustment movements. For example, clavicle has to rotate posteriorly, the AC joint has to rotate upwardly, and also the sternoclavicular joint has to roll superiorly to adjust itself. If one element is not moving or is stiff, we see that the range of motion won't be complete in that scenario. In some conditions, such as scapular winging due to long thoracic nerve palsy, or dyskinesia due to poor neuromuscular control, when the force coupling doesn't work properly, we see that the scapulohumeral rhythm is impaired. So it was a brief introduction to the shoulder kinesiology and biomechanics. In the next video, I'm going to talk about the elbow kinesiology and biomechanics. Thank you for watching this video.